All right, I think we can get started. So I see people are introducing themselves in the chat. That's terrific. Hello, everyone. Welcome to the 7th annual Shkreli Awards. I'm Vikas Saini, president of the Lown Institute. We're happy to have you all here today. The Lown Institute, as many of you know, is an independent think tank. We advocate for bold ideas for a just and caring system for health. We're working to refocus healthcare on what's best for people. That includes hospitals that care for those most in need, patients living without the fear of financial distress, and health professionals finding joy and fulfillment in their jobs. This year at Lown, we're celebrating our 50th anniversary as an organization. Our signature project, the Lown Hospitals Index for Social Responsibility, is a nationally recognized ranking, the first of its kind to include measures of equity, overuse, along with traditional outcomes metrics. You can see more about the index and all of our innovative projects at our website, lowninstitute.org. So today we're here to present the Shkreli Awards. As you heard, it's our 7th year. The Shkreli Awards are our top 10 list of the most egregious examples of profiteering and dysfunction in healthcare, named, of course, after the infamous pharma bro, Martin Shkreli. So throughout the year, we gather examples from the news and recruit an esteemed panel of judges, clinicians, health policy experts, journalists, and patient advocates to choose the worst of the worst. When we started the Shkreli Awards, we realized how powerful it is to see all of these stories together. It's not just that they're shocking, though almost all of them really are. It's also how starkly they illuminate what needs to change in healthcare in America. So here at Lown, we believe a radically better system is possible, but we can't achieve that unless we're honest about the problems. We need to begin shifting the norms of what's acceptable. And the Shkreli Awards are brutally honest. So let's get started by introducing our guest hosts today. Harriet Washington is a medical ethicist and award-winning author, as well as a lecturer in bioethics at Columbia University. Her works include Medical Apartheid and Deadly Monopolies. Harriet, please take a minute and tell us a little bit about your book, Deadly Monopolies.
Certainly. In 1980, a suite of laws was passed in this country that enabled and encouraged industry to acquire and profit from university research, the research that you and I fund with our tax dollars. Well, unfortunately, this partnership has resulted in a very lopsided partnership where industry has produced a profit-centered, a profit-oriented medical culture, and the patent has replaced the patient at the center of the healthcare universe. Healthcare is now a commodity, and everything from the high price of medication to the dearth of medications for important ailments like malaria stems from the sea change. In the US, patients go bankrupt trying to maintain their health, but abroad, in the developing world, people simply die. So we definitely need another radical change. The reverse of when we had in 1980, laws that will enable medical research culture to reinvent itself and focus upon the patient. That's what the book is about.
That's excellent. I'm going to have to read it. There's a lot more I could say, but thank you for being with us. Victor is a clinician, researcher, and healthcare innovator. Dr. Victor Montori practices as an endocrinologist at Mayo Clinic in Rochester and is the author of the book, Why We Revolt. His book serves as a conceptual framework for the patient revolution, a global movement for careful and kind care. Victor, please tell us a little bit about your organization.
Thank you very much, Vikas, and it's a pleasure to be here with you, Harriet, and with you, Vikas, on this infamous occasion. The Patient Revolution is a global organization of care activists focused on transforming healthcare from an industrial activity where we process people into one where people come together to care for, about, and with each other, and achieve careful and kind care for all, which is what healthcare should be about. Why We Revolt is a book that summarizes our aspiration, and this opportunity serves me to invite everyone that finds activities of the Lown Institute compelling to also join Patient Revolution as our care activist, as a fellow.
Great. Thanks, Victor. It's great to have you here. Well, without further ado, let's get down to the 7th annual Shkreli Award countdown. So, number 10, a hospital threatens to ship expensive and comatose patient out of the country. When a patient at Lehigh Valley Health Cedar Crest Hospital in Pennsylvania was still in a coma weeks after surgery, her family hoped she'd get continued care there. However, the patient's undocumented status put her future in jeopardy. According to a story in the Philadelphia Inquirer, the hospital gave the family an ultimatum: pay $500 a day for the equipment they'd need to care for her at home, or find another facility that would take her, or consent to a, quote, medical deportation, unquote, to the Dominican Republic. They had 48 hours to decide. Thanks to protests from immigration activists, the patient was transferred to a different hospital in the state. Lehigh Valley Health Network did not comment on the woman's case, but said that it works tirelessly with patients and their families to ensure that they receive appropriate care. Well, there's a lot to say here, so many different dimensions. Victor, why don't you take a first stab at it?
I think at first look, this is obviously an example of cruelty, a phenomenon that occurs in healthcare when healthcare organizations, and of course the people within those organizations, appear to be making decisions that are indifferent to the suffering and challenges of the patient, in this case, this unfortunate individual. What makes this complex and unfortunately common is that immigrants to this country that may not have the right documentation for their status fall into a category like other groups that don't deserve the treatment with dignity and respect that other members of society would. And as a result, it seems like there's more permission for them to be treated with indifference and cruelty. And we will see through the list other examples. In this case, it happens to be an individual who did not have all adequate documentation to be in the country. The one point to keep in mind as we read these stories is, what does this do to the integrity of the health professionals involved in the decision-making process? So as we see the cruelty landing on the patient and the family, who now, in addition to have to deal with the health issues, they have to deal with the legal and disposition issues, and even the threat of being removed from the country as a result of this. We also have to think about what happens to the moral integrity of the health professionals who are on the other side of that decision, perhaps seeing their commitment to care violated by this action.
Harriet, what are your thoughts? Have you heard about something like medical deportation? Is that a thing?
I've heard of it often. As Victor suggested, it is not at all a rare circumstance. Dramatic circumstances actually banish them from the country, but quote unquote dumping patients at bus stops, even in parking lots, has made the news frequently. And I think it points to, it's nuanced certainly, but it points to a very clear decision about what are the predominant values. If the predominant values are adhering to the law, then the immigrant status or the undocumented status might provide a rationale for doing this. Not a moral rationale though. And that means that we have to decide whether we're going to be, healthcare workers are going to be directed by the law or by ethical standards. By ethical standards, it's hard to defend something like that. And it's also, I think, once again, like many of these situations, also point to a decision we have to make about whether healthcare is a commodity like any other, or is it special? Is it privileged? Should dollars not be able to dictate someone's medical fate? I think it's a really clear case of that here. Unfortunate that our decision tends to be adhering to laws that may not have ethical outcomes.
Indeed. A good friend of mine, actually, my roommate from boarding school, is a lawyer in Canada and had a case like this in which a woman was undocumented, an illegal immigrant, if you will, seriously ill in the ICU, and he basically took that, and the Canadian healthcare system wanted to refuse to pay for it or cover her, and that went all the way to Supreme Court, and they lost the case. Then it went to the United Nations, to the Council on Human Rights or whatever, where they won the case. But what it illustrates, I think, is something we're going to see repeatedly today, which is that there's often a contradiction between the letter of the law, the logic of the marketplace, and the real situation of people in the world today. So let's move on. Number 9, physician payments help medical device maker test experimental procedures and products on the poor and patients of color. Surgeons can earn compensation from device maker Medtronic for letting other doctors watch them implant the company's products. But to get that cash, they need to find patients for which the devices are appropriate or not. According to the LA Times, a surgeon at Harbor UCLA Medical Center, a hospital that serves mostly lower income patients and people of color, convinced a patient to have 2 experimental $15,000 Medtronic devices implanted, even though her condition may not have warranted such a procedure. The patient, Bernetta Higgins, ended up having a stroke and months later was still learning how to walk again and talk again. Higgins had worked at a law firm before the stroke, but after the surgery, she couldn't even write her own name. Harriet?
Well, sadly, there are several important issues here, all of them bad. And one of them, most obvious one, is informed consent. If she was given erroneous information about her need for the device, then she was not privy to having informed consent. And the hospital in question actually conducts a lot of emergency research without consent, which again is illegal under federal statutes, has been legal since 1996. And so it's another example of research without informed consent, or frankly, sometimes any sort of consent. And that's an issue, both legal and ethical. But the larger issue to me is historical. This is a very, very old practice that has affected predominantly African Americans and poor people. Hospitals in this country were initially allowed Black people and poor people into their hospitals without paying or very low pay in order to use them as medical training material. Everything from demonstrating an illness, showing a medical student what a hepatic ulcer looked like, to performing unneeded and unwarranted surgeries in order to show the medical students how to do it. And we only know of this because the owners of these slaves would complain that they would send perfectly healthy slaves to the hospital, thinking they'd be boarded for free, and the slave would come back missing an arm, which had been removed in order to show medical students how one does an amputation. This is a very, very old pattern in this country, and it's very dangerous because these are the very same people, Black people and poor people, who were constantly telling to trust the healthcare system. You can trust us, the past is the past. But when news of something like this happens, it affects far more than the few people whose lives are ruined. It affects the many people who read of this and say, just as I've always thought, these hospitals are dangerous places, and who will avoid healthcare. And certainly that's dangerous, not only for the people who need healthcare, but also for medical research and medical training. If you're making people afraid of participating because they're afraid of being treated like this patient was, then our problem is not going to go away.
Well, we're only at number 9. I don't know what to say. I mean, I will say I'm not sure who actually gets the Shkreli here. There's so many players involved. It's really an ecosystem, and I think that's the other lesson I think we can all take from this. There's a little more background. We don't have time to go into it, but at the time the patient was admitted, the physician involved had 36 research projects going with this device company, Medtronic, and got paid as much as 100,000 for that. And there's a whistleblower suit. There's all sorts of things going on, and I think it illustrates another dimension, which is access, as you say, Harriet, access to sort of the clinical material for research, such as it is really being given away for free, as it were. So I'm going to go on. I'm sure you had something to say, Victor, but I got to keep moving here. Number 8, hospitals allegedly dump sick, homeless patients on the street. Something you just mentioned, Harriet. Despite a California law meant to prohibit the practice, hospitals are regularly engaging in patient dumping of homeless people. According to a story in the San Diego Tribune, one activist told the Trib that she encountered as many as 500 homeless people who had been, quote, dumped, unquote, by hospitals in the last year. In one case, a patient who was on hospice died desperately afraid in the park, according to his wife. Meanwhile, in Louisville, Kentucky, television station WAVE filmed an elderly woman lying on the sidewalk across from a hospital in 36-degree weather. They were following a tip from a hospital employee who said that she saw the patient being dumped from the wheelchair. And you can see that picture in the slide here. Another Louisville man at another hospital who shattered his hip and pelvis in a car crash was dropped in front of a homeless shelter instead of a rehab facility. He was quoted as saying, "I felt like a worthless man. We're garbage." According to a statement from one hospital named in the story, quote, "When individuals without a medical need refuse community support and refuse to leave, there's no option left but to lead them off the property. It's an unfortunate reality, but we must make room for the hundreds of others who do need medical care." So, I don't know what to say. We know of 3 hospitals in these stories, but my guess is there's many others. When I practiced for 30 years, I know there are circumstances in the ER where it becomes absolutely intolerable and there is no way out, it seems. So I think what we're seeing is a symptom of a very deep and very pervasive problem. We could all pontificate at length about it, but I think at the heart of the matter, whatever the mitigating factors, whatever elements you could see in the system, whoever you might point the finger at, when you see that picture, it's just wrong. Victor?
I feel very emotional, frankly, because this is offensive to the commitment that we make to care. And as you said, I think it's a symptom of a larger problem, which is the problem by which human life is an instrument of other goals and objectives. And that not just the hospitals, but hospitals and healthcare institutions represent the values of the communities and societies in which they operate, or sometimes exacerbated or made more dramatic or tragic. But the idea that there are some people among us that do not get to benefit from our community's embrace and are left in the cold is not limited to those individuals when they're sick and have to leave the hospital to make room for another person. So it is the problem of homelessness compounded by the challenges of providing care in healthcare organizations that are overcrowded, perhaps. There's another twist to this, which is, of course, the notion, again, of the not only of this is not only offensive to the people that receive this sort of treatment, but in the story, there's evidence, as you pointed out, because that the people involved seem to have no other way out. They had no other solution to offer these folks. And the moral challenge that has to be for those who retain their humanity, it has to cause the kind of injury that burns people out and forces people out of care. And those who don't respond that way have a degree of callousness built into them, where dumping this human out of the system is what you do to this enemy that is crowding my emergency department, and I need to get rid of them. So to create more space, these are just moving bodies around. So that either we have then emergency room filled with individuals who are not do not have the emotional position to care, or those who are in an emotional position to care are burning out and leaving the practice because of having to experience this in their activity. So this is horrible for the people that have suffered this and for their families if they are still connected to them. Some folks in homelessness don't, but it's also incredibly injuring to those who are still in healthcare to care.
Yep. Well, over 20 years watching ER staff deal with this, confirms everything you're saying, Victor. There's a lot more to say. We don't really have time, but I think these deep-seated issues, this one in particular, which I think is the intersection of the housing crisis, a mental health crisis, and a substance abuse crisis, all three of those, I don't think they're going to be fixed with a new program or a change in a budget. I mean, those things are important. I think it's going to require a change in culture, change in the actual networks and social fabric. So there's a lot of work for all of us. Okay, number 7. Any narrowed artery seems a fair target for this alleged coronary stent king. So according to WTHR 13 News, 7 patients have filed malpractice complaints against Indiana cardiologist Edward Harlemert for unnecessary cardiac stents, misdiagnosis, unnecessary medications, and more. One patient received 41 stents during 44 heart catheterizations, including some stents placed inside existing stents that had become clogged with scar tissue. And in a video deposition, Harlemert did not deny placing as many as 80 to 90 stents in a single patient. According to the physician's attorneys, Dr. Harlemert has always been committed to providing quality care to patients. And the picture you see here on the slide is a real advertisement online featuring Dr. Harlemert for a screening test that could potentially lead to coronary stents or other interventions. Having done a lot of, being a cardiologist and having done a lot of work on overdiagnosis and overtreatment, I think I can say that slide and the $49 rate is really the gateway drug for a lot of mischief. You start looking at stenoses, you want to open them. It's the oculocardiac or oculostenotic reflex. The other thing I'll say is, I've seen in my own practice some of my more, I guess the polite word would be aggressive treatment of my colleagues, where, they might do a redo stent or maybe a third time, maybe 3 or 4 stents or all the way down the artery. The slang for that is full metal jacket. I think if I saw 10 or 15 stents in somebody, I'd start saying, hey, wait a minute. But the idea of 80 stents in one person, I mean, I don't even know what to say. It's remarkable. Anyway, we have done a report on stent overuse, and our estimate was that about 1/5 of Medicare patients who are getting stented, probably getting it for stable coronary disease where it's not indicated. So this has been going on. I mean, the coronary stent thing has been discussed and reported on for a couple decades. Harriet, any thoughts on the persistence of this kind of disconnect between the evidence and the practice?
At first glance, this looks clearly like the triumph of greed over good healthcare. But I think there might be other things going on. I'm sure this is prevalent in many patients with varying economic profiles. But what I read about most frequently is Medicare patients being subjected to this, which makes me question whether Medicare is sufficiently vigilant in terms of monitoring doctors who do procedures to make sure that they are warranted. There was a case just, I think, last year of an ENT doc being sentenced to 25 years in jail after reusing single-use devices on patients and collecting millions of dollars. And I thought, my first thought was, how could it go on so long that, $50 million changed hands and so many patients were affected? It seems to me that more vigilance is needed here to protect patients, since we obviously can't rely on every single doctor to put healthcare first.
Indeed. Number 6, heartburn treatment had a dirty secret that the company hid for decades. As far back as the 1980s, GlaxoSmithKline had evidence, both from its own research and independent studies, that its heartburn med Zantac, which I'm sure you've all heard of, could result in the formation of a carcinogenic compound. According to a Bloomberg article, the company downplayed the issue and even withheld a key study from the FDA. Zantac went on to become one of the best-selling prescription drugs of all time, and over decades helped drive the transformation of GSK into a $73 billion company. That is until 2019, when the FDA finally caught up with them and forced the drug off the market. Today, GSK has admitted zero liability. Analysts, however, estimate the pharma giant will pay out as much as $5 billion to settle related lawsuits. A reformulated version of Zantac has been offered since 2021, so now it may be safer. But the key ingredient in the old version has also found a new purpose. Researchers use it to induce cancer in lab rats. Harriet.
Well, that last statement, that speaks for itself, right? Unfortunately, it's not limited to Zantac. I wrote an article for the American Scholar in which I pointed out how medical journals are vulnerable to the data they receive, whatever comes over the transom. And some companies and the researchers whom they pay are willing to lie and withhold information. COX-2 drugs, very expensive, drugs that were used very widely until it emerged that the researchers had withheld information from the medical journals about the strokes and heart attacks that are being triggered. This has happened repeatedly, many times. And so this kind of deceit seems to be very difficult to pin down and prevent until people have been injured. I'm also put in mind of an infamous case, at least to me, of Forest Laboratories versus the United States, in which US prosecutors discovered that the laboratory had actually withheld information about dangers of medications from its own researchers. They were siloed and no one could see the results from people's research. The company knew of the dangers, but they withheld that information from researchers who thought that the drug they had tested and were now vetting and prescribing was a good drug. So I think we need a legal framework to address these problems before they get so far out of hand. Forcing manufacturers to be truthful about all the results of the research, about all the injuries.
Victor, thoughts?
Just briefly to say that this looks like an anecdote, and we can go into the legal issues, also the regulatory capture that might be implied in the delay of the FDA from action and holding this company accountable. But there's also another angle here, which is the problem of misinformation in medicine. that this allows people to speculate about the safety of other devices, products, medicines, and vaccines, create hesitancy among people who are most vulnerable to disease, and create a distance, a barrier for the adoption of effective and safe medications and treatments. And it's situations like this that have this collateral harm that we saw so clearly during the pandemic, and that make this particularly problematic.
Yep. Yep. A lot more to say there. There's a lot of ideas, policy ideas for how to fix this. I mean, they wouldn't be popular with pharma, I'm sure, but there's no question that there are ways to address this. The business model, the FDA, all of that needs a revamp. Well, let's take a break. We're only at the halfway mark, but let's take a break and just reflect a little. I know it doesn't look great in American healthcare based on everything we've been talking about. If we want to build a new health system, we'll need strong leadership in the next generation. There's no doubt about it. And these young clinicians need to know that they're supported, that there is a community out there, and that their voices will be heard, and that they'll have friends and allies in the work they do. That's why we created the Bernard Lown Award for Social Responsibility, or what we call affectionately Blazer. Think of it as an anti-Shkreli Award. The Blazer is given each year to a young clinician who demonstrates bold leadership in healthcare reform, racial equity, environmental justice, or any other humanitarian effort outside the clinic. Previous winners have included Dr. Mona Hanna-Attisha, the pediatrician who helped uncover the Flint water crisis, and Dr. Altaf Sadi, a neurologist and health justice advocate for immigrants who played a role in debunking the so-called condition of, quote, excited delirium, unquote. So if you and our audience know of any young clinician taking action on social or humanitarian issues, nominate them for the Bernard Lown Award at lowninstitute.org/award. The deadline for nominations is the end of this month, so you've got a few weeks left. And now back to the Shkrelis. Number 5, despite discipline in a dozen states, vascular doc Dr. James McGuckin keeps on trucking. What happens to a doctor's career once he's been disciplined by medical boards in a dozen states, lost privileges at multiple hospitals, and settled allegations of Medicare fraud for performing unnecessary procedures? Well, if you're Dr. James McGuckin, you get to keep on practicing. According to a report by ProPublica and the Philadelphia Inquirer, McGuckin and his vascular clinics received extensive scrutiny for experimental or unnecessary procedures on patients, including some who lost legs to amputation or nearly lost their lives. In Washington State, McGuckin was required to write an essay to pass an ethics course. He failed twice, and the evaluators noted that he wasn't able to, quote, demonstrate a capacity to think ethically about why he is being held to account, unquote. He did eventually pass on his third try with the help of a tutor. As of August, he was still practicing in Pennsylvania. McGuckin's attorney said that he has never been found personally liable for fraud and that the government's most recent allegations are provably wrong. Victor?
It's unbelievable, isn't it? There is, I mean, I'm interested in going after the non-obvious, right? I think anybody that looks at this, can begin to see all the different ways in which this is highly problematic. I want to raise attention to the investigative journalism that actually uncovers some of these examples. One of the victims of the evolution of both social media and now with artificial intelligence is independent journalism rooms. and the investigative reporters, the kinds of people that take this and bring light to it and show it to us and make us not only give awards, but ask questions about how is it that someone who has been found to have a practice that at the very least offends the ontology of medicine and the ethical practice of patient care, continues to do so, perhaps, not perhaps, almost for sure, with their patients unaware that this concerns have been raised and unable to then make an informed choice as to whether they should receive care from such a practitioner. So I want to recognize the independent and investigative journalism that allows us to see this and ask us as a society to find ways of protecting it from the threat of both the social media companies and the and those whose interests are actually offended by.
Thanks, Victor. Couldn't agree more. I think investigative journalism is critical. When I see this story, the other thing that just keeps nagging at me is there's this huge missing piece of the jigsaw puzzle, which is some systemic way of monitoring these sorts of things. We saw it even in the prior one about Medicare and the number of stents. There's a missing component here. And in many ways, my thought is we've got an infrastructure that sort of is in a fantasy of 1920s solo practitioner doctors, Marcus Welby, an FDA that, does this and does that. And we're living in the 21st century with AI and social media and a winner-take-all culture. We don't have the infrastructure to deal with this, and we need to create something, I think. Harriet?
Because hold on, sir, but one point to make to that, if I may, is that at the same time, you have clinicians completely overwhelmed by pre-authorization and documentation requirements to do the things that patients actually do need. So to me, it's amazing that these people have the ability to get authorization to put 80 stents and conduct this work when I can't get my patients to refer the medicines they actually need.
Right. Absolutely. I mean, it just illustrates the whole, the mechanics of this are seriously broken. I will say, having practiced prior auth is a pain in the butt. It's ridiculous 99% of the time. On the other hand, I have friends who've gone off and joined the dark side and become medical directors at insurance companies. And they tell me stories of things I'm like scratching my head. Why would the person even want to do that? Harriet?
Well, I don't think I have much to add to the excellent points you've all made, but I think that I empathize with the burden that a lot of the documentation puts on physicians, but I often feel that we're documenting the wrong things. Ethics needs to be considered part of the clinical picture and needs to be predominant in decision making. And it's important to hire leaders on clinical floors who take ethics seriously. If they take it seriously, their people under them will take it seriously. But I think the documentation of not only adverse outcomes, but of inappropriate behaviors is something we don't like to do. We valorize physicians, and we should. We hold them to higher standards, but also we have to understand that malfeasance is not going to stop by itself. And I think we need to document more of this and have very carefully delineated guidelines for behaviors, probably more carefully than they need to be for most doctors, but for the occasional doctor one we're discussing, we'll need this kind of guidance. So I think that we need to revisit what we ask doctors to document and how we ask them to behave and what we ask them to prioritize. Skills are essential, but so is empathy, and so is a understanding of ethics.
Indeed. Okay, number 4. Credit where credit's due. These hospitals have a medical debt solution for you. Need an expensive, life-changing surgery, but scared of the cost of hospital care? You could look into financial assistance policies or payment plans to see if you qualify for help. Or You could take the advice of some hospitals and apply for a high-interest medical credit card instead. According to KFF Health News, hospitals across the US are embracing relationships with private equity-backed companies to offer medical credit cards. These cards often have attractive interest-free introductory payments. But when that period ends, interest rates skyrocket, often as high as 26%. For example, before UNC Health started contracting with the lender Access One, most patients were in no interest plans. Now, 100,000 UNC patients are in Access One plans, with almost half of them at the highest interest rate offered. In its defense, UNC Health said they have, quote, a responsibility to remain financially stable to assure we can provide care to all, regardless of ability to pay, unquote. So really what we're saying is we got to be sure we extract as much as we can from the ones we have in order to be able to do it again in the future. We need financial stability. Victor?
There is an extension of this, which is much more common, less egregious, which is when nonprofit hospitals argue that they need, that no money, no mission, right? That's the mantra. And there is a slight confusion then that follows, by which they switch the no money, no mission to where they've become much more aggressive at increasing their volume of care in order to make more money. In other words, we need to see more patients so that we can generate the income that we need to keep the lights on, which we need to see more patients. So seeing patients and caring for patients goes from being the reason of existence of the organization, the end of the organization, to become the means by which the organization advances. And it is by turning patients into the means, patient care into the means of financial ends, that we then lose track of the fact that we are, that this is an inversion of what we're trying to do. We need the resources to care for people, and I think a lot of the examples that we've seen today, they turn patients into, I think at some point somebody made an illustration of as ATMs, and the system just draws resources from that, and they convince themselves that the reason that they're doing is to remain financially viable, but it's an inversion of mission with resources.
Just yesterday, Stat News had a piece just reporting from day one of the JP Morgan conference, talking to hospital CEOs about their, the money in the bank, the deployment of investment. And it was pretty clear patient care is, what I tweeted out was, patient care is more of a loss leader for all the other stuff. Because they were saying they can't make money taking care of patients. And that may well be true. So there's a lot to figure out and fix. But I think you're absolutely right, Victor. I don't see how we have even halfway intelligent conversations about this sort of thing without getting into the question of how we finance healthcare, how we pay for it, to what extent is the burden going to be borne by individuals and patients who are sick, and to what extent is it going to be more generalized across society, whether or not we're paying different prices for the same treatment, or whether or not we're paying different amounts depending on what insurance you have. If you don't address these questions, these things are not going to be fixed. The business side is not going to be fixed. Harriet, we got to move on, but I'll give you a minute if you want to jump in.
Well, very quickly and relatively crudely, I admit, it's loan sharking while wearing the mask of benevolence.
Yeah. Okay. Well, 26% interest. Yeah. That free period reminded me of my Hulu subscription, which I forgot to cancel. All right. Here we are. We're down to the final three. This is the inner circle. Number 3, Medicare drug price negotiation tests the constitution of big pharma. As a result of the Inflation Reduction Act, Medicare will for the first time be able to negotiate with manufacturers over drug prices. This will make it easier for older Americans to afford their cancer, heart disease, and diabetes medications, and save the government an estimated $100 billion over the next decade. That is, unless a flurry of big pharma lawsuits puts a stop to it. At least 9 pharmaceutical companies or trade organizations have challenged the new law so far, with all of them claiming some violation of their First, Fifth, or Eighth Amendment rights. For example, some claim that being forced to negotiate is a form of compelled speech, since they may have to say that a price they disagree with is actually fair. While the outcome of most suits is yet to be determined, a federal district judge did reject one attempted injunction, noting that the drug company's participation in Medicare is voluntary. So what would the founding fathers say about this? If you're, I'm not a lawyer, thankfully, but it really is a question of how you determine, free speech. We already know corporations are persons, and we already know that they have, quote, free speech rights, but is actually having to negotiate the price of your product or having the option of walking away, is that some form of compelled free speech? My reaction is really to say, nobody's asking you to agree with it. Nobody's asking to say it's fair. They're just asking you to agree on the price if you want to sell the product. So I'm with the drug, if you don't like it, you can walk away. That should be how that negotiation goes. Harriet?
I don't, frankly, have a great deal of admiration for the founding fathers, but I do think that if a organization wants to remain silent because of the chance that they will have to admit that their prices are unfair, that's an admission right there. So my advice to them would be to walk away. Don't join the Medicare program and leave those dollars behind. We know they won't do that, but it is a choice. And if you don't want to conform to the law, then you should walk away.
Yeah. By the way, the Fifth Amendment relates to due process. So it's not just self-incrimination, but due process in general, and what's called the takings clause. The Eighth Amendment is about excessive fines and, quote, cruel and unusual punishment. So I think this is interesting as an argument. Victor, we got about a minute from this one if you want to jump in.
No, let's move on.
All right. Number 2, nonprofit hospital pays CEO stunning salary. What would you do with $35.5 million? Produce an independent film, undertake an affordable housing project, or wipe out the medical debt of 50,000 Americans? Well, if you're Common Spirit Health, the largest Catholic healthcare system in the US, this is what you paid your CEO, Lloyd Dean, in 2021, according to a report by Stat News. For comparison, Dean's total compensation was nearly $15 million more than the CEO of the nation's largest for-profit health system that year, and that includes stock options. Why so much? According to Common Spirit's tax filing, their, quote, executive compensation philosophy, unquote, is designed to help the company promote patient and employee satisfaction and improve the quality of life in the communities they serve, among other things. Common Spirit didn't return a request from Stat News, who broke this story, for comment. Victor, it's all yours.
No, not all mine. But I suspect that that's something that is said in the boardroom when these salaries are discussed. It's all mine. I think there is an extension here of the logic that we have been seeing through this, which is that that there is a at the same time, we don't have the resources to care. We don't have the, our place is overcrowded. We cannot keep this homeless person here too long. We cannot keep this patient that is is an undocumented immigrant here too long. We don't have the resources. We cannot pay our nurses appropriately. We cannot pay our junior doctors and our senior doctors, that are in the front lines adequately. We cannot pay our technicians adequately, and so forth. And you see these resources just getting concentrated at a high level at the top. And I have heard the argument that it is at every level an organization needs to offer competitive payment to attract the best and the brightest to lead the organization. At some point, it becomes offensive to the goals and missions of an organization, particularly one that is mission-oriented, to dedicate so much resources to the well-being of one person at the detriment of the well-being not only of their staff, of the people that they're putting in front of folks to care for them, but also for their ability to pursue the actual mission that the organization has. I am very envious of these levels of income, except that they have a way of changing one's world's view, because you no longer live with the people that you're serving. You live in a bubble in which other people with this level of compensation live, and that ain't the real world in which the people you are leading work and the people you're serving seek the care that you need. And that creates a distance that actually makes you a poor leader. So I think it's in the worst interest, not in the best interest, the worst interest of the organizations to produce such an income bubble around their top leadership, because it prevents them from having a common spirit with the patients that they're actually serving and the clinicians that they're putting in front of them.
Yeah, couldn't agree more. I mean, we know from research, survey data, behavioral economics, you reach a certain number, and you're not happier. As Silicon Valley likes to say, it's just a way of keeping score, right? But there's lots of other ways of keeping score, aren't there? We could have an Academy Award of the most socially responsible hospital CEOs. That would be recognition. I think that's worth something. It's probably much more satisfying in some sense. So I completely agree with you. It does set the tone, but I also think we cannot ignore the fact that it is a result of the broader culture. There's a lot going on in the broader culture, and that's part of it. Harriet?
Well, Victor alluded to the mission of this hospital's institution. And there are two missions. There's a stated mission, which is all about increasing healthcare, maximizing care for the individual. But there's the real mission. What is he being paid $35 million to do? To bring more money in, period. So he's paid to do that, to maximize profits for the shareholders and for the staff of this organization. And that means behaving exactly like any other corporation. As I alluded to at the very beginning of our talks, that has been the sea change in American healthcare, moving from values and missions dictated by people who want to cure, medical researchers and physicians, et cetera, and now being dictated by corporations who want to maximize profits. So he's earning his $35 million, and he's being paid to do what they want him to do, which is not the stated mission. And I think that there are people who, of course, know that, but I think a lot of patients may not realize that. And It's important for us to make it clear, the disconnect here between what's stated and what's real.
Well, and I think the other important dimension is this is a nonprofit entity, which is to say it has tax breaks granted to it by communities. All right, it's that magic moment. Number one in the 2023 Shkreli Awards. Years of complaints failed to stop Columbia OBGYN physician from sexually assaulting patients. Despite evidence of an ongoing problem, Columbia University OBGYN Robert Haddon assaulted patients for years with little intervention by the administration. That's according to ProPublica and a New York Magazine joint report. Overall, more than 245 patients have come forward to allege abuse, including one woman who hadn't had delivered as a baby. According to the report, Columbia failed to hand over subpoenaed evidence, referred patients sharing new complaints to their own general counsel rather than to the DA, and allowed Haddon to return to work within a week of his arrest, as long as he agreed to have a chaperone. Haddon was eventually sentenced to 20 years in prison in July 2023, while Columbia has agreed to pay out more than $235 million to settle two separate lawsuits, admitting no responsibility in the matter. So maybe they admit no responsibility, but the Shkreli Award, maybe it goes to Haddon. It certainly has to go to Columbia as well. Harriet, what do you think?
What Haddon did, violent crimes against women, for which he was essentially unpunished for a long time, hundreds of women, is horrible. But it's more horrible to understand that he is not unique. There have been physicians who have abused women and men for decades at institutions like Harvard. The best schools in the country have harbored these people over years and decades without scrutinizing or publishing them and without believing the women who have come forward with complaints. Not that people should be automatically believed, but some attention and investigation should have followed strings of complaints about these physicians. It's very insidious. Atlanta Journal and Constitution and New York Times both did articles detailing how this is a national scourge. It's not limited to New York City. It's not limited to Columbia. It's something that's happening across our country that we are permitting to happen. Women being sexually abused, raped, and men too, for decades. And what makes it especially heinous in my eyes is that physicians are exceptional people, and we expect more from them. We expect a higher degree of moral behavior. We expect to be able to trust them. We get naked in front of them. We allow them to render us unconscious. We give up power in so many ways to physicians because we trust them. And this abuse of trust is completely unacceptable. Again, some of these victims did not come forward because they understood that they themselves would end up being on trial. And some of them understood that nothing would happen to their person they were accusing. But some people did come forward, and the university or the police simply did not listen to them. And I think it's really important to understand that this goes back to another trust issue. It's yet another example of why, at the same time we bewail the fact that some groups of people don't trust the medical system, this is allowed to go on, which completely obliterates the chance of any trust in these people. So what they're doing is particularly heinous because they are physicians and they are trusted.
Well said, Harriet. We don't have time, Victor. I know you would agree, and I know you would have a lot to say. I'm sure some of it you touch on in your book, Why We Revolt. And maybe that is what needs to happen. So that's it for our 2023 Shkreli Awards. You can see the descriptions for all the winners, along with comments from our judges panel on our website. We want to give a huge thank you to our hosts, Harriet Washington and Victor Montori. Harriet's book, Deadly Monopolies, is available online, and you can follow her on Twitter at HAW95. Learn more about Victor's organization, The Patient Revolution, at patientrevolution.org, and follow him on Twitter at Victor Montori, at V Montori, sorry. To see more events like this one and to get more healthcare news throughout the year, subscribe to our free weekly newsletter at lowninstitute.org. Subscribe. Thank you all for coming to the 7th Annual Shkreli Awards. But remember, it's not all doom and gloom. We hope to see you all in a few months when we announce the winner of the Bernard Lown Award for Social Responsibility. We'll see you then.